Right. So a very good afternoon to everyone. I welcome you all to this particular YouTube session where I will be discussing the clinical based questions on neurology. So I am myself Dr. Rajesh Guba. I am the general medicine educator for Arise Medical Academy. Right. So in order to see that you should not face any difficulties in upcoming FMGE exam, we at Arise Medical Academy have started this particular clinical based questions. Okay. So please utilize these free sessions, right, where we are discussing exclusively the clinical based sessions, and try to see that definitely you should crack your exam in your upcoming December 4th date. So this session will be the clinical based questions on the neurology. Neurology is one of the very important area in the general medicine where many number of questions will be asked, and that is also a little difficult area where to make out the diagnosis also will be little difficult. So we will try to approach the neurology in a very conceptual manner, and we will try to solve the questions as many as possible. Okay. Right. So now let us start with the first question. We have a 1 second. Yes. We have a 64-year-old man presents with symptoms of tremors and generalized feeling of slowing down, right? Generalized feeling of slowing down. His tremor bothers him most on his left side. His past medical history is significant for depression, hypertension, and hyperlipidemia. For depression, he is taking fluoxetine, and for hypertension, he is taking lisinopril, and for hyperlipidemia, he is on atorvastatin. On physical examination, he has a resting tremor with the presence of the cogwheel rigidity. When observing his gait, you note slow shuffling steps with difficulty maneuvering to turn around. His facial features shows decreased range of emotions and appear somewhat fat. Eye movements are completely full. Mental status examination shows normal mentation. And what are you suspecting? You are suspecting Parkinson's disease in this patient. What is your first choice of therapy? Defer therapy until further diagnostic studies are performed. Levodopa, carbidopa, rotigotine, selegiline, either B or C can be used. Right. So what is this case of? This is a case of Parkinson's disease. Right. Already diagnosis itself is given. Right. So Chandrasekharan has answered levodopa, carbidopa. Right. So does everyone agree with Chandrasekharan, or do you have any other answer? Okay. Even Arya Ajesh also said levodopa or carbidopa. Okay. Now let me tell you what exactly is the answer. Does anyone have any other answer apart from levodopa, carbidopa? Yes. Does anyone have any other answer apart from levodopa, carbidopa? Very good, Arya Ajesh. Now you have answered it correctly. So either you can give levodopa, carbidopa, right, or the rotigotine can be given. Either of these can be given. Okay. Now, what I wanted to tell you from this question is that you should be completely aware of all the features of Parkinsonism. Number one, Parkinsonism, it is seen in elderly individuals. That is first thing. And the next important point, Parkinsonism, it is characterized by a triad. There will be presence of tremors, right? There will be rigidity, right? And there will be slowness of movements. right? There will be slowness of the movements. Okay, so this is a triad in Parkinsonism, right? This is the triad in Parkinsonism, and you see all the features of that particular triad is there. Tremor is there, right? Rigidity is also there. Then followed by that, there is also slowness of the movements which are present in these individuals. So this is a classical case of Parkinsonism now, no doubt. Already the question itself is telling you now. But the point what I wanted to impress upon you is that if the question is asked like what is the first choice of therapy, the first choice of therapy in the previous days, it was levodopa carbidopa, right? What is your levodopa? Levodopa is the one which will give you dopamine supplementation, right? And why carbidopa is added? Carbidopa is added because, right? Carbidopa is added because this carbidopa, it is a peripheral decarboxylase inhibitor. Right? It is a peripheral decarboxylase inhibitor. Now, because it's a peripheral decarboxylase inhibitor, what it will do? It will inhibit the decarboxylation of the levodopa. Right? It will inhibit the decarboxylation of levodopa. Now, what will happen if the peripheral decarboxylation occurs? If the peripheral decarboxylation occurs, levodopa is converted into, right? Levodopa is converted into dopamine, and dopamine cannot cross the blood-brain barrier. Dopamine cannot cross the blood-brain barrier. Now, what is the purpose of giving levodopa instead of just dopamine? Why? Because dopamine does not cross the blood-brain barrier. It is the levodopa which will cross the blood-brain barrier. So that is the reason why we give levodopa instead of dopamine. Even though in Parkinsonism, what exactly is the pathology in Parkinsonism? Decrease in dopamine. So it will be sufficient if you just give dopamine itself. But the point is, if you just give only dopamine, dopamine cannot cross the blood-brain barrier. So in the place of it, we give levodopa. Levodopa can cross the blood-brain barrier. But the point is, this levodopa will undergo peripheral decarboxylation. And in order to inhibit that peripheral decarboxylation, we give this carbidopa. Right? We give carbidopa. Now, I will ask you one more question. In the place of levodopa, in the place of carbidopa, right, in the place of carbidopa, is any other peripheral decarboxylase inhibitor added to levodopa? Any one of you? In the place of carbidopa, any other peripheral decarboxylase inhibitor, can it be added? Yes or no? If yes, what is the other peripheral decarboxylase inhibitor in the place of carbidopa? Can anyone answer this? So the answer is, in the place of carbidopa, the other drug that can be replaced is benserazide. Right, the other drug that can be replaced is your benserazide. Okay, so levodopa can be combined with benserazide also for the treatment of Parkinsonism. Right, for the treatment of Parkinsonism, in the place of carbidopa, benserazide can also be added. Okay, right. Now apart from this particular levodopa carbidopa in patients with Parkinsonism, in the recent days what has been approved is rotigotine is also approved. Now the question is, what is your rotigotine? Right, the question is, what is your rotigotine? Remember, your rotigotine is also the drug which is definitely useful for your Parkinsonism patient, and it is a dopaminergic agonist. So many providers now prefer dopamine agonist as the first line therapy. Now, what is the examples of your dopamine agonist? The dopamine agonists, they include pramipexole, ropinirole, and as well as rotigotine. So these are dopamine agonists. Right, these are dopamine agonists. Okay, even though these dopamine agonists efficacy is not equivalent to levodopa, right? The efficacy of this particular dopamine agonist is not equivalent to that of levodopa, but the advantage of this particular dopamine agonist is they have very few motor complications, right? They have very few motor complications. Now, what is the adverse effect of your levodopa? The adverse effect of levodopa is that the individual can have on-off phenomenon, right? The individual can develop what is called on-off phenomenon. But that particular on-off phenomenon or that particular motor complications is not there with the dopamine agonist. So that is the reason why many providers now prefer dopamine agonist as a first line therapy, right? First line therapy. Okay. Now, what are those dopamine agonists? Pramipexole, ropinirole, and as well as the rotigotine. Okay, and it should be noted that even with the use of dopamine agonist, eventual treatment with levodopa is required in most of the patients. That means in spite of giving rotigotine, right, in spite of giving this particular rotigotine, you should also supplement the patient with the levodopa. Right, you should also supplement the patient with the levodopa, right? So that's a very important point that you need to remember. Next, the other group of drugs that is given in the treatment of Parkinsonism is monoamino oxidase inhibitors. And what is this monoamino oxidase inhibitors? One is selegiline and the other drug is rasagiline. Right, one is selegiline and the other drug is the rasagiline. So these are the monoamino oxidase inhibitors. Okay, now I will ask you one important question. What are the examples of COMT inhibitors that are given in the treatment of Parkinsonism? COMT inhibitors given in the treatment of Parkinsonism. Any one of you, please. Right, so who will be the first person to answer? What are the COMT inhibitors? So COMT inhibitors stands for catechol O methyl transferase inhibitors. And these COMT inhibitors are entacapone and as well as the tolcapone. Right, entacapone and as well as tolcapone. These are the COMT inhibitors that is given in the treatment of Parkinsonism, right? And you take these monoamino oxidase inhibitors. If you use monoamino oxidase inhibitors as monotherapy in early disease, there is risk of serotonin syndrome, right? There is risk of serotonin syndrome. That is the reason why monoamino oxidase inhibitors like selegiline and rasagiline, they are not used as the monotherapy, right? They are not used as the monotherapy. Okay, so this is the answer for this particular question now. So what is the answer? Either you can give levodopa carbidopa as a first choice. You can also give the dopamine agonist, that is rotigotine. What is selegiline? Selegiline is a monoamino oxidase inhibitor. This selegiline is not given as the monotherapy because of the risk of the serotonin syndrome, right? Because of the risk of the serotonin syndrome. Okay, so the answer is E. Either B or C can be used as a first choice therapy in Parkinsonism. Right, now we will move on to the next question. Yes, which of the following statements regarding Parkinsonism is true? Cigarette smoking reduces the risk of developing the disease. Old age at presentation is more likely to be associated with genetic predisposition. Parkinson disease has been identified as monogenetic disorder related to mutation in alpha-synuclein protein. The typical age of onset of the symptoms is about 70 years. The hallmark pathological feature of Parkinsonism is the presence of neurofibrillary tangles and tau proteins in the substantia nigra compacta. So the question is, which of the following statement regarding Parkinsonism is a true statement? Yes, so who will be the first person to answer which is the true statement? So I have totally 3 questions on Parkinsonism, right? Parkinsonism is one of the very important area in the neurology where the question can be expected with high chance. Okay, so Aman has answered Parkinsonism disease has been identified as monogenetic disorder. Okay. Remember Aman Minhas, Parkinsonism, it is not a monogenetic disorder, right? It is a polygenetic disorder. It is not a monogenetic disorder. Okay. Now, let me also show you what is that particular genes which are affected in Parkinsonism. It is not a monogenetic disorder. Okay. So Sandeep Chandra and as well as Chandrasekharan has answered E. It is diagnosed as the presence of neurofibrillary tangles and tau proteins. Oh my God. Remember, neurofibrillary tangles and as well as the tau proteins, where are they present? They are present in the patients with the Alzheimer's disease, not in your Parkinsonism. Right? Tau proteins and neurofibrillary tangles, they are present in Alzheimer's disease, not in patients with the Parkinson's disease. Now, so your option C is gone, option E is gone. Okay, so Arya Ajesh has come with a point with B. Older age at presentation is most likely to be associated with the genetic predisposition. Always remember, in any disorder, not only in Parkinsonism, any disease which has genetic predisposition, that means what? It has been inherited, right? That means it has been inherited. So if a disease is inherited, you don't have the older age at presentation. They usually present in a young age, right? Yes, Arya Ajesh. They present at young age. They don't present at the older age. Yes. So second option is ruled out. Second option is gone. Now then, yeah, now then only 2 options are left out. A is left out and D is left out. So can anyone opt in between A and as well as D? Right, I'm waiting for the answer. Someone should select either A or D. Right, so both the options have been selected by different students. So Arya Ajesh and Chandrasekharan has selected the typical age of onset of symptoms is 70 years. Let me tell you, the typical age of onset of the symptoms is around 60 years. It is not 70 years. Right, it is not 70 years. Yes, so your option B is also the wrong statement. Right, option D is also the wrong statement. So what is the answer which is left out now? Very good, Shahid Afridi and as well as Benjet. The answer is A. Cigarette smoking reduces the risk of developing the disease. right? Cigarette smoking reduces the risk of developing the disease. Okay. Now, let me go into a detail of the discussion of this Parkinson disease. Okay. So, first of all, let me tell you, Parkinson disease, it is the second most common neurodegenerative disease. Right? Second most common neurodegenerative disease. What is first most common? The first most common is your Alzheimer's disease. Right? First most common neurodegenerative disorder is Alzheimer's disease. And this point already I have said you that the age of onset of the symptoms is around 60 years, but not 70 years, right? But not 70 years. Next. Now, genetic predisposition, right? This is what the Arya Ajesh was telling. The frequency of Parkinsonism increases with age, but present as early as the third decade of life, right? But present as early as the third decade of life in genetic predisposition, right? In genetic predisposition. Okay, right. So presents at a younger age in those individuals who has the genetic factors, okay, right? And some of the student was, yeah, some of the student have selected monogenetic disorder. Let me tell you, Parkinsonism, it is not a single gene disorder, right? There is no single gene found to be associated with the Parkinson's disease. Now, it is polygenetic, right? What are all the genes which are affected? The most likely genes to be altered in Parkinson's disease include, number one, alpha-synuclein gene. Number two, Parkin gene. Number three, LRRK2 gene. So these are all the genes which are being affected. And apart from that, many others have been identified. But remember, it is not a monogenetic disorder, right? It is not a monogenetic disorder. Now, apart from the genetic component, you also have the other risk factors like exposure to pesticides, rural living, and drinking of the well water, right? So these are the other predisposing factors. And now this is the correct answer. This is your option A, right? This is your option A. Cigarette smoking and caffeine are associated with reduced risk of Parkinson's disease. Right? Now, this cigarette smoking, I wanted to ask you one important question. What are all the diseases that can be prevented by cigarette smoking? What are all the diseases that can be prevented by cigarette smoking? Yes, who will be the first person to answer all the diseases that can be prevented by cigarette smoking? Right, so this should be on your fingertip, right? Or this should be on your tongue tip. Very good, Sandeep Chandra. Ayyo, Chandrasekharan. COPD can be prevented by smoking, right? Are you joking or like what is that your answer? Mukesh Pal, good. Alzheimer's disease. Next, one more. One is ulcerative colitis. Next is Alzheimer's disease. One more disease that can be prevented by your smoking. Commonly seen in females. Not commonly, only seen in females. What is that? Acha, it's okay, Chandrasekharan. Fine, no problem. Right. So the other disease that can be prevented is very good, Benjet. Very good. Super, Benjet. That is endometriosis. Right? Endometriosis. So these are the diseases that can be prevented by your smoking. Endometriosis and as well as endometrial carcinoma can be prevented by your cigarette smoking. Right? Now, where is the pathology in Parkinsonism? The pathology in Parkinson's disease is there will be degeneration of dopaminergic neurons in substantia nigra pars compacta. right? Degeneration of dopaminergic neurons in substantia nigra pars compacta. Right. Now, the very important thing is you should know what are the inclusion bodies. The inclusion bodies in Parkinsonism, right? The inclusion bodies in Parkinsonism, it includes Lewy bodies, right? It includes Lewy bodies, which are intracytoplasmic inclusions, right? Which are your intracytoplasmic inclusions. Okay, and what does this Lewy body contain? This Lewy body contain alpha-synuclein protein, right? It contains the alpha-synuclein protein. Now, what is given in your options? In your options, what has been given is tau protein is given in your options. Now, where do you get this tau protein? The tau protein is present in the Alzheimer's disease. Right, it is present in Alzheimer's disease, but not in case of the Parkinson's disease, right? Next, so that was completely about the question on Parkinsonism. So, cigarette smoking reduces the risk of developing the disease. Correct statement. Older age at the presentation is most likely to be associated genetic predisposition. No, genetic predisposition. The onset of the clinical manifestation is around third decade. Right? Parkinson's disease has been identified with monogenetic disorder. No, it is polygenetic. Right? The typical age of the onset of symptoms is about not 70 years, 60 years. The hallmark pathological feature of Parkinsonism is the presence of, right, the presence of Lewy bodies. Right? The presence of Lewy bodies with alpha-synuclein protein. Right, with alpha-synuclein protein, right, within the substantia nigra pars compacta, right? Right. Now, yes, Arya Ajesh, like why smoking decreases the disease? See, it has not been explained anywhere clearly, but the toxins which are present within the smoking, right, toxins which are present in the smoking, they are found to neutralize, right? They are found to neutralize the pathogenesis of the Parkinsonism. In that way, the smoking will decrease the risk of Parkinson's disease, right? So what exactly is the toxin? What level of the pathogenesis is being neutralized, right, is not being explained anywhere. But this is the predictable theory, how smoking will be reducing the risk of Parkinson's disease, right? Next. Now, one more last question on Parkinsonism. Which of the following patient with Parkinson disease is the best candidate for deep brain stimulation? Best candidate for deep brain stimulation. A 64-year-old woman on levodopa carbidopa who continues to experience episodes of freezing while walking. A 68-year-old man with recurrent falls due to orthostatic hypotension. 70-year-old women with severe tremors unresponsive to dopaminergic therapy. 71-year-old man with worsening symptoms of dementia. All of the above patients will respond to deep brain stimulation. Right? So deep brain stimulation is what? It is one of the surgical treatment in patients with the Parkinsonism. Right? So what do we do here? We place an electrode. Right? We place an electrode within the basal ganglia. Right? We place an electrode within the basal ganglia. Right. Very good, Chandrasekharan. So Chandrasekharan has answered it correctly. 70-year-old women with severe tremors unresponsive to dopaminergic therapy. That is the indication for your deep brain stimulation. That is the indication for your deep brain stimulation. Now let me explain you. So deep brain stimulation is the most common surgical therapy performed for Parkinson's disease. In this surgery, the electrode is placed in the target area. And what is the target area? The target area is in the subthalamic nucleus or globus pallidus pars interna. So where will you place the electrode is also the multiple choice question. The electrode is placed either in the subthalamic nucleus or globus pallidus interna. Now the electrode which is placed, the electrode which is placed in the target area, it is connected to a stimulator. And where is this stimulator placed? This particular stimulator is placed in the chest wall. Right? This stimulator is placed in the chest wall. Now, what exactly is the mechanism by which the deep brain stimulation works is not known. But what the deep brain stimulation has been found was, deep brain stimulation, right? It is associated with disrupting, right? It is associated with disrupting abnormal signal associated with Parkinson's disease and motor symptoms. So by doing deep brain stimulation, which symptoms will be reduced is very, very important, right? It is only motor symptoms that will be reduced. Right? It is only the motor symptoms that will be reduced. So that is the advantage of your deep brain stimulation, right? And what is the primary indication for the deep brain stimulation? The primary indication for deep brain stimulation is the presence of severe tremors in spite of giving levodopa. Right? Or the other indication is levodopa induced motor complications. Levodopa induced motor complications, we use this particular deep brain stimulation. And let me tell you, this particular deep brain stimulation, right, it will not respond the frequent falling of the patient. It will not respond the freezing of the patient. It will not respond the dementia of the patient. Right? It will not respond the falling, it will not respond the freezing, it will not respond the dementia. And it will also not respond the postural hypotension as well. Orthostatic hypotension is also not responded by your deep brain stimulation. So, to summarize deep brain stimulation in Parkinson's disease is a surgical treatment. In deep brain stimulation, the electrode is placed in the substantia nigra, right? It is placed in the substantia nigra, subthalamic nucleus. I'm very sorry. It is placed in the subthalamic nucleus or globus pallidus internum. And the electrode is connected to stimulator which is placed in the chest wall. Now, this particular deep brain stimulation, it will reduce the motor symptoms associated with the Parkinson's disease. And the primary indication of the deep brain stimulation is severe tremors not responding to therapy. Number 2, levodopa induced motor complications. We keep this deep brain stimulation. This deep brain stimulation will not resolve freezing, will not resolve orthostatic hypotension, will not resolve dementia. So that is the reason why the answer to this question is your C. That is the reason why answer to your question is C. That is a 70-year-old man with severe tremor, unresponsive to your dopaminergic therapy is the correct statement, right? So these 3 questions are very, very important questions related to your Parkinsonism, right? And let me tell you, clinical based questions, every day I'm doing for 1 hour or half an hour. Please watch all the sessions. Don't miss any of the sessions. You should not regret after the exam in a way that I should have watched the clinical based sessions that would have been useful for this exam. Please don't feel or please don't face that particular regrets, right? Whatever the hard work and whatever the efforts you have to keep, please keep your efforts at this moment of time for your preparation. After the exam, if you regret, it will be of no use, right? So please watch all the clinical based discussions, image based discussions, which I have done on the YouTube. Okay, right. Now we will move on to the next question. Right, so if you see the next question, a 54-year-old man presents complaining of weakness, right? Complaining of weakness. He had difficult time pinpointing an onset, right? When is exactly the onset of weakness is not known, right? What exactly is the onset of the weakness is not known. He believes he first noticed weakness in the right foot, right? He believes that he first noticed the weakness in his right foot and leg. That means in the right lower limb about 6 months ago. Okay. Now he reports that he frequently trips, right? Trips over his toes and drag his foot. Now what do you understand by that? Trips over his toes and drags his foot. That means the foot. Why is he dragging the foot? Because he has developed foot drop, right? Because he has developed foot drop, and that is the reason why he is dragging the foot. He is unable to lift the foot from the ground. Next, he also gets frequent cramps when he stretches in bed in the morning. The other important complaint is cramps. The other important complaint is cramps. Now, the weakness is progressive to involve both the legs now. So from the right lower limb, even the left lower limb is also affected, right? Even the left lower limb is also affected. And on examination, you note the fasciculations on the tongue. So now what is that you are noticing? You are noticing the presence of fasciculations over the tongue on examination. The deep tendon reflexes, they are 3+. Right, deep tendon reflexes, they are 3+, and strength is 4- at the extensors and flexors of the right foot and 4+ at the left foot, and hand grip strength is also 4+. That means the power is reduced. Which of the following is suspected pathological causes of this patient's symptoms? Right. So which of the following is the suspected pathological cause of this patient's symptoms? Now, right. Now, tell me what is the diagnosis, right? What is the pathological cause of this particular patient's symptoms? Yes, anyone? Okay, so some of you have answered it correctly already. That is A and C. Degeneration of the corticospinal tract and loss of the anterior horn cells within the spinal cord. Right? So the answer is E. The answer is E. But please tell me, what is the diagnosis of this clinical scenario? Right? Please tell me, what is the diagnosis of this clinical scenario? Any one of you? Yes, Sai Taruni. What is the clinical diagnosis? So now what does this patient has? This patient has foot drop and this patient has the fasciculations. So the presence of foot drop and as well as the fasciculations, these are your lower motor neuron symptoms, right? These are your lower motor neuron symptoms. And the deep tendon reflexes 3 plus. 3 plus deep tendon reflexes means it is exaggerated, right? You have exaggerated deep tendon reflexes. That means exaggerated deep tendon reflexes, where will you have? You will have this in upper motor neuron lesion. Very good, Chandrasekharan. So Chandrasekharan has answered it very clearly and very nicely and correctly. It is the individual is having both upper motor neuron lesion and lower motor neuron lesion. Where will you have that? You will have that in patients with the amyotrophic lateral sclerosis. Right? You will have that in patients with the amyotrophic lateral sclerosis. Okay. Now, let me tell you a few points about the amyotrophic lateral sclerosis now. So, amyotrophic lateral sclerosis, it is a motor neuron disease. Right? Amyotrophic lateral sclerosis, it is a motor neuron disease. Now, in amyotrophic lateral sclerosis, both upper motor neuron is affected and lower motor neuron is also affected, right? And the word itself tells you motor neuron disease. That means purely motor nerves are affected, right? Purely the motor nerves are affected, right? Purely motor nerves are affected. And in motor neuron disease, there is no sensory involvement. Right? In motor neuron disease, there is no sensory involvement. Now, in amyotrophic lateral sclerosis, the prognosis is a very bad prognosis. Right? The prognosis is very bad prognosis. And the cause of death in these patients is due to respiratory failure. Right? The cause of death in these patients is respiratory failure. Yeah, yes, Chandrasekharan, correct. The Stephen Hawking's, right, he had that particular amyotrophic lateral sclerosis. Now, yes, Chandrasekharan, can you tell me what is the drug of choice for amyotrophic lateral sclerosis? Even though we use the word supportive therapy in amyotrophic lateral sclerosis, the treatment what we give is only just a supportive therapy. But there are certain drugs which can prolong the life of the individual. Can anyone tell me what is the drug of choice for amyotrophic lateral sclerosis? Yes, Sai Taruni, the neurology is over for you in ARISE. Very good. So Aman Minhas is answered correctly. Very good, Aman. So the answer is Riluzole. The answer is Riluzole. Okay. Now, apart from this particular Riluzole, we have a new drug now. Right? We have a new drug. What is this new drug for amyotrophic lateral sclerosis? What is the new drug for amyotrophic lateral sclerosis? Acha, neurology is finished. Who has taught neurology? Yes, Sai Tarni, who has taught neurology? So the new drug in case of amyotrophic lateral sclerosis is edaravone. Right, the new drug in case of amyotrophic lateral sclerosis is edaravone. So this is a new drug for the treatment of amyotrophic lateral sclerosis. Right. So now motor neuron disease means you don't have only UMN LMN lesion. Let me tell you the motor neuron disease of various types. What are those? That is, you have motor neuron disease where there is involvement of both upper motor neuron and lower motor neuron, right? The diagnosis is amyotrophic lateral sclerosis, right? Diagnosis is amyotrophic lateral sclerosis. And there are certain motor neuron diseases where you have only upper motor neuron involvement. And there are certain motor neuron diseases where there is only lower motor neuron involvement, right? Where there is only lower motor neuron involvement. Now, you should be very much aware what are the motor neuron diseases where upper motor neuron is affected, right? And what are the lower motor neuron diseases where what is a motor neuron disease where the lower motor neuron is affected? Acha, Singaram sir has taught. Okay, fine. Right. So, motor neuron disease where the upper motor neuron is being affected is the primary lateral sclerosis. Right? It is your primary lateral sclerosis. And motor neuron disease where the lower motor neurons are being affected is spinomuscular atrophy. Right? Spinomuscular atrophy. Okay. Now, if the question is asked among all these three types of motor neuron diseases, right? Among all these three types of motor neuron diseases, the most common is amyotrophic lateral sclerosis. Right? The most common is your amyotrophic lateral sclerosis. Okay. So that is about the motor neuron disease. That is about your motor neuron disease. And the question which has been given in this clinical scenario, you have both upper motor neuron involvement and lower motor neuron involvement. And what is that upper motor neuron affected? Corticospinal tract. And what is that lower motor neuron affected? That is your anterior horn cell. And what is the diagnosis in this case? It is amyotrophic lateral sclerosis. Right? It is your amyotrophic lateral sclerosis. Right? So this is about, right? So this is about the clinical scenario of motor neuron disease. Right? Next, we will move on to the next clinical scenario. Yes, the other clinical scenario, if you see here, I have a 58-year-old woman, right? And she came to me with complaints of very sharp pain lasting about 1 minute over her right cheek and as well as lips, right? Lasting about 1 minute over her right cheek and as well as the lips. These pain episodes occur in clusters. Right? These pain episodes occur in clusters with intense pain during the episode. When an episode occurs, it is present both day and night and may reoccur over a period of about a week. Right? These particular episodes, they will reoccur over a period of about a week. Paroxysms of pain, that means sudden onset of pain, can be elicited by washing her face. Right? Whenever the individual washes her face, there will be paroxysms of pain. On physical examination, there is no sensory loss and there is no motor loss in the right face. And there is no masses as well. But upon touching the right face, right, touching the right face does bring about an episode of pain for the patient. Right, touching the right face does bring about an episode of pain for the patient. What is the next best step in the management of this patient? Initiate treatment with carbamazepine 100 milligrams with gold dose of 200 milligrams. Perform an MRI or magnetic resonance angiography of the brain. Third option, refer the patient for a temporal artery biopsy. Fourth option, refer the patient for electromyography and nerve conduction studies. Fifth option, refer the patient for microvascular decompression surgery. Yes. So I want someone to crack the diagnosis. Yes, someone should crack the diagnosis first. Any one of you, please. Now, yes, Afridi, what is the diagnosis? Why are you answering B? Why you want to do MRI of the brain? Yes, tenso. Right. Very good, Sandeep Chandra. Right. Very good, Sandeep Chandra. So, and even Chandrasekharan and even Sai Taruni, the diagnosis is trigeminal neuralgia. Very good. So when the diagnosis is trigeminal neuralgia, right, when the diagnosis is trigeminal neuralgia, then what is the treatment for trigeminal neuralgia? What is the treatment for trigeminal neuralgia? Any one of you? Right? Yes, can anyone tell me what is the treatment for trigeminal neuralgia? What is the drug of choice for trigeminal neuralgia? For trigeminal, yes, very good, Charak Roy. So Charak Roy has answered it correctly now. So initiate the treatment with carbamazepine 100 milligrams with a gold dose of 200 milligrams that can be given. So drug of choice for trigeminal neuralgia is carbamazepine. Right, carbamazepine. See, the clinic, if you take the clinical picture in case of trigeminal neuralgia, the picture is very clear. The clinical picture is very clear that the individual is having very sharp pain. The individual is having a very sharp pain in the right cheek and as well as the lips. And upon touching the face, right, upon touching the face, what is happening to the pain? The pain is getting precipitated. The pain is getting precipitated upon touching the face. Okay, and even on washing the face also the pain is getting increased. All these are the features of your trigeminal neuralgia, right? So let me tell you a few points about trigeminal neuralgia. So trigeminal neuralgia, it is due to compression of, right, it is due to compression of trigeminal nerve root, right? It is due to compression of the trigeminal nerve root. And this trigeminal nerve, it has three branches, right? It has three branches. One, ophthalmic. Next, maxillary. And then mandibular. These are the three branches of the trigeminal nerve. Now, the point here is that, right? The point here is that the maximum clinical features of trigeminal neuralgia, they are present in the maxillary distribution. Right? Maximum clinical features of trigeminal neuralgia, they are present in the maxillary distribution. Right? That's a very important point. Okay. Now, in ophthalmic distribution also there can be features of trigeminal neuralgia. Mandibular distribution also there can be features of trigeminal neuralgia. But maxillary distribution of the trigeminal nerve has maximum clinical manifestation. And ophthalmic division, what do they have? In the ophthalmic distribution of the trigeminal nerve, they have they have your discharge of the eyes. This we call it as autonomic symptoms, right? This we call it as autonomic symptoms. So autonomic symptoms, right? Autonomic symptoms of your trigeminal neuralgia, they are more common, right? They are more common along the ophthalmic distribution. What is that autonomic symptoms? Discharge from the eyes. Next, redness of the eyes, right? Redness of the eyes. So these are your autonomic symptoms. These are your autonomic symptoms of the trigeminal neuralgia, which are present in the ophthalmic distribution, right? Now after having discussed about these features of trigeminal neuralgia, let me explain you the character of the pain of trigeminal neuralgia. As I have already described in the clinical scenario, the pain of trigeminal neuralgia will be very sharp pain and it will last for few seconds, right? It will last for few seconds and the pain of the trigeminal neuralgia will increase upon touch, right? Will increase upon smiling, will increase upon washing the face, right? And the features of trigeminal neuralgia will increase upon exposure to cold air, right? Upon exposure to cold air. So these are all the precipitating factors for your trigeminal neuralgia. These are all the precipitating factors of trigeminal neuralgia. All right. So now after having discussed about the character of the pain of the trigeminal neuralgia, now let me tell you the drug of choice. Drug of choice, that is what I have said you. Drug of choice for trigeminal neuralgia is carbamazepine. 100 milligrams you have to start, right? 100 milligrams you have to start. Now if suppose if the patient is not responding to your carbamazepine, what is the next thing what you have to do, right? What is the next thing you have to do? If the patient is not responding to your carbamazepine, the next drug what you have to give is oxcarbamazepine. Right? Oxcarbamazepine can be used. Now, apart from oxcarbamazepine, the other drugs that can be given is lamotrigine and as well as dilantin. These drugs, they can be tried. Right? These drugs, they can be tried for the treatment of trigeminal neuralgia. Now, you have given all the drugs, right? Carbamazepine given, oxcarbamazepine given, lamotrigine is given, dilantin is given, but still, right? But still, the patient is complaining of the pain of trigeminal neuralgia. In that case, you need to do a surgical intervention. Right? In that case, we do surgical intervention. Right? And what is that surgical intervention? That is microvascular decompression. Right? Microvascular decompression. Okay? Right? Or the other alternative procedure is you resect the root of the trigeminal nerve. That is rhizotomy has to be done. Right? Rhizotomy has to be done. So these are the treatment options for your trigeminal neuralgia, right? And the next option is gamma knife radiosurgery may also be tried. Right? Gamma knife radiosurgery may also be tried. Okay, and rhizotomy is done with radio frequency thermal rhizotomy is used less frequently, right? Less frequently. Okay, so that is about your question on the trigeminal neuralgia. That is about the question on trigeminal neuralgia. So here the drug of choice is carbamazepine, right? And microvascular decompression surgery should be done later. If the patient is not responding to any medical therapy, then you need to do microvascular decompression surgery. And you refer the patient for temporal artery biopsy. When will you do temporal artery biopsy? You will do the temporal artery biopsy if the patient is suffering with the temporal arteritis. Right? If the patient is suffering with the temporal arteritis, which is a large vessel vasculitis. This temporal arteritis, it is also called giant cell arteritis. But whatever the character of the pain which has been given here, it is not at all your temporal arteritis. In temporal arteritis, I will tell you what will be the features. In temporal arteritis, the pain will be, the individual will have headache, mostly unilateral headache. Right? Mostly unilateral headache. And they will have a very tender temporal artery, sclerosed, thickened temporal artery. Right? And you will be able to palpate that particular temporal artery. Right? You will be able to palpate that particular temporal artery. Okay? And in these patients with the temporal artery, you have other manifestations also, like there can be sudden onset blindness because of the involvement of the ophthalmic artery. And these patients, they also have jaw claudication. Right? They also have jaw claudication. Right? Next, now the other important point that you need to know in temporal arteritis, in almost 40% of patients, right? 40% of patients, they suffer with what is called polymyalgia rheumatica. Right? They suffer with what is called polymyalgia rheumatica. So what is polymyalgia rheumatica? Polymyalgia rheumatica is stiffness of, right? Stiffness of the shoulder girdle and hip girdle. Right? Stiffness of the shoulder and as well as the hip girdle. That is what is called as the polymyalgia rheumatica. So these features of polymyalgia, these features of temporal arteritis is not there in your patient, right? They are not there in your patient. So why do you want to refer the patient for temporal artery biopsy? It is a wrong statement, right? It is a wrong statement. Now about the diagnosis of trigeminal neuralgia, right? So if you take the diagnosis of trigeminal neuralgia, diagnosis of trigeminal neuralgia, it is mostly clinical diagnosis. Right? It is mostly clinical diagnosis. That is the presence of sharp shooting pain, which is present for few seconds, precipitating by smiling, brushing, touching, grimacing, mostly clinical diagnosis. Then what is the, for confirmation, you can do MRI of the brain. Why? In order to look for, is there any mass that is compressing the trigeminal nerve root? Right? In order to look for, is there any mass compressing the trigeminal nerve root? Okay, so that is the purpose why you need to do MRI. That is the purpose why you need to do MRI, right? So that completes, right? You have to do MRI, but in this patient, what is the next best step in the management? We are very clear with the diagnosis. When we are very clear with the diagnosis, you give carbamazepine directly. Why you want to do MRI of the brain and waste the money of the patient? Please don't do that, right? In a doubtful cases, or if you want to make out if there is any mass compressing the trigeminal nerve root, then in such case you do MRI of the brain. Otherwise, we don't require to do the MRI of the brain in patients with the trigeminal neuralgia, right? So this is a very, very important clinical question related to your trigeminal neuralgia, right? This is in total about trigeminal neuralgia. Now we will move on to the next question. Yes. Right. So this is another very interesting question, and let me see how many of you can crack this question. We have a 32-year-old woman presents for neurological evaluation and experiencing severe burn on the palm of her right hand. right? Complaining of severe burn on the palm of her right hand. She has placed her hand on the hot surface of smooth electric range. But the point is, she did not feel the burn. This is very, very important point. Right? She did not feel the burn when it occurred. And only when she picked up her hand up did she notice the burn. After that, it was discovered that patient unknowingly had bilateral loss of pain and temperature sensations in both the hands. However, she does have touch and vibratory sense. Right? She does have touch and vibratory sense. Mapping of her loss of sensations shows decreased pain sensation in the nape of the neck. Right? Decreased pain sensation in the nape of the neck, shoulder, upper arms, as well in a cape-like distribution. So that loss of sensations are there in a cape-like distribution. The deep tendon reflexes, they are absent at the biceps and as well as triceps. And there is visible muscle wasting of the right biceps and shoulder musculature. What is the most likely diagnosis? What is the most likely diagnosis? Right, very good, Asadullah Khan. So the diagnosis in this clinical scenario is you need to do Syringomyelia. Right, you need to do Syringomyelia. So sorry, diagnosis is Syringomyelia. I'm very sorry. Now let me explain you in detail about the Syringomyelia. Right. So what is the complaint of this woman? The complaint of her woman is she burnt her hand. Right, she burnt her hand, but she did not feel the pain. But she did not feel the pain. Okay, that is one point, right? And the next point is there is bilateral loss of pain and temperature. Right, there is bilateral loss of pain and temperature. I'm writing only positive points, okay? Next, and when mapping of her loss of sensations has been done, right? When mapping has been done, the mapping showed the sensory loss in the cape-like distribution. Right? Mapping showed the sensory loss in the cape-like distribution. Right? Next, the other point is the touch and vibratory sense, they are preserved. That means what? Touch and vibratory sense means the posterior column sensations are preserved. Right? Posterior column sensations, they are preserved. Right? Posterior column sensations, they are completely preserved. And the deep tendon reflexes, they are lost. Deep tendon reflexes, they are absent at the biceps and as well as triceps. So this is the summary of the clinical scenario. This is the summary of the clinical scenario. Right. So, very good. So, Charek Roy has answered correctly. Sai Taruni answered correctly. Asadullah Khan, right, answered correctly. So, this is a case of Syringomyelia. Now, what is Syringomyelia? How do you treat Syringomyelia? Right? And how do you investigate for Syringomyelia? Everything let me take up now. So, Syringomyelia, what is the definition is? It is the disorder where you have dilatation of central canal of the spinal cord. Right? Dilatation of central canal of the spinal cord. And predominantly in the which area? right? Dilatation of the central canal of the spinal cord is predominantly in which part of the spinal cord? It is mainly in the cervical spinal cord, right? It is mainly in the cervical spinal cord. Now let me show you the image also, right? So this is the image of Syringomyelia, right? So central canal of the spinal cord, it is completely dilated, right? It is completely dilated. Okay, how is it dilated? It is dilated by a fluid filled cyst, right? It is dilated by a fluid filled cyst. Now what I will do is I will just show you the cut section now. Let me show you the cut section of this particular spinal cord with a fluid filled cyst. Right, let me show you a cut section of this particular spinal cord with a fluid filled cyst. Now, this is how the cut section will appear. What is that? This orange color, whatever is there, this is your fluid filled cyst. Right, this is your fluid filled cyst, where exactly in the center of the spinal cord. Right, exactly at the center of the spinal cord. Now let me try and explain to you in a very conceptual manner what is happening due to the presence of cyst. Due to the presence of cyst, what actually is happening? Let me try and explain to you. What is happening is this particular cyst, where exactly it is present? In the center of the spinal cord. Now, in the center of the spinal cord, right, in the center of the spinal cord, what are the tracts which are present? The tracts which are present in the center of the spinal cord, they are your spinothalamic tracts. Right, they are your spinothalamic tracts. Now, right, now, what does this cyst do? This particular cyst will cause damage to this particular spinothalamic tract. You see here, the blue color one, whatever you are seeing here, they are your spinothalamic tract which are crossing from one side to the other side, right? Which are crossing from one side to the other side. So this particular cyst will cause destruction of the spinothalamic tract. Now, spinothalamic tracts, what are the sensations carried? The sensations carried by your spinothalamic tract is pain, temperature, right? Pain, temperature, and as well as the crude touch. These are the sensations which are carried by your spinothalamic tract. Now, what is your cyst doing? The fluid filled cyst. The fluid filled cyst is destroying this spinothalamic tract. When your fluid filled cyst is destroying the spinothalamic tract, your pain sensation is lost, temperature sensation is lost, crude touch is also lost. That is the reason why she was not feeling the burnt hand, right? She was not feeling the burnt hand. Now, the other point is this particular cyst is commonly located in the cervical spinal cord. Right, this is commonly located in the cervical spinal cord. Now, you take the cervical spinal cord. What does the cervical spinal cord contain? Cervical spinal cord, it contains the spinothalamic tracts which are coming from your hands. So, in the cervical spinal cord, if there is cyst, the spinothalamic tracts of the hands, right, the spinothalamic tracts of the hands, they are completely destroyed. So when the spinothalamic tracts of the hands are completely destroyed, the individual cannot feel the burning sensation of the hand. Right, the individual cannot feel the burning sensation of the hand. And not only that, this particular spinothalamic tracts, right, not only that, this particular spinothalamic tracts which are present in the cervical spinal cord area, right, which are present in the cervical spinal cord area. Remember, they also bring the sensations from the nape of the neck. They also bring the sensations from the shoulders, and they also bring the sensations from your hands. So that is the reason why the sensation which is being lost, this we call it as cape-like distribution. Right? This we call it as the cape-like distribution. That is what is the clinical scenario which has been given to you. Right? That is what is the clinical scenario what has been given to you. So the sensations which are being lost is cape, in the cape-like distribution. Which sensations lost? Pain and temperature sensations are lost. Right? Pain and temperature sensations are lost. Now the next question is, the next point is, touch and vibratory sense, they are preserved. Right? Touch and vibratory sense, they are preserved. That means which sensations are preserved? The posterior column sensations are preserved. Now the question is, why the posterior column sensations are preserved? Now we will go back to the image again. Now if you take this particular cyst, right, if you take this particular cyst, what is this cyst doing? The cyst is only damaging the spinothalamic tracts. Right, the cyst is only damaging the spinothalamic tracts. The dorsal columns, they are preserved. Right, dorsal columns, they are preserved. That's a very important point. Dorsal columns are preserved. So when the dorsal columns are preserved, because the cyst is not expanding in the posterior direction. The cyst is not expanding in the posterior direction. The cyst is expanding laterally. The cyst is expanding laterally. So posterior columns or the dorsal columns, they are preserved. So when the posterior columns or when the dorsal columns, when they are preserved, there is no loss of, right, there is no loss of vibratory sense. Right? There is no loss of vibratory sense. There is no loss of the fine touch. Right? There is no loss of pressure sensation. There is no loss of conscious proprioception. That means the posterior column sensations, dorsal column sensations, they are preserved. Right? They are preserved. Okay? Right. That I have explained you now. So I have explained you why the posterior column sensations are preserved. Next, the other thing what I should explain you here is the deep tendon reflexes. The deep tendon reflexes, they are absent. Which one? Biceps and as well as triceps reflex are lost. Now the question is why? Why the biceps and triceps reflex is lost? So now you see the point here, right? You see the point here. In these individuals, where is the compression? This particular compression, right, this particular compression of the by the cyst can expand laterally, right, can expand laterally. Now when the cyst is expanding laterally, which particular tracts can be compressed? Even your corticospinal tracts also can be compressed, right? Even your corticospinal tracts also can be compressed, right? Now when corticospinal tracts are compressed, there will be damage to your upper motor neuron, because your corticospinal tract is an upper motor neuron. Right? Now you see the discussion. Sir, when the upper motor neuron is damaged, the reflexes should be exaggerated. The deep tendon reflexes should be exaggerated. But here the biceps reflex is lost, absent. Triceps jerk is absent. How is it possible, sir? You are saying that the cyst is expanding laterally, right? You are saying that the cyst is expanding laterally and it will compress the corticospinal tract. And if the corticospinal tract is damaged, there should be upper motor neuron signs. Upper motor neuron signs means the biceps jerk should be exaggerated, triceps jerk should be exaggerated. But in our clinical scenario, to our patient, bicep jerk and tricep jerk is absent. How will you explain this? Now let me explain that. Now, You take in your spinal cord lesions, right? In spinal cord lesions, remember, right? In spinal cord lesions, remember, at the site of lesion, right? At the site of lesion, you will have LMN palsy. In spinal cord lesions, at the site of lesion, you will have LMN palsy. Below the site of lesion in the spinal cord, you will have UMN palsy. You will have UMN features. Upper motor neuron features will be there. Now, the point is, where is the cyst present? The cyst is present in the cervical spinal cord, in Syringomyelia. Right? When the cyst is present in the cervical spinal cord, the cervical spinal cord is compressed. The cervical spinal cord is compressed. That means where is the site of lesion? The site of lesion is at the cervical spinal cord. Now, what did I tell you? At the site of lesion, you will have LMN features. Right? At the site of lesion, I said you that you will have LMN features. Okay. Now, you take your biceps jerk and you take the triceps jerk. What is the root value of this biceps and triceps jerk? The root value of your biceps and sorry. Right. What is the root value of your biceps jerk and triceps jerk? Biceps jerk has a root value of C5 and C6. Right? And triceps jerk, the very important root value is C6. That means, where is the origin? The origin is from the cervical spinal cord. What is your cyst doing in the Syringomyelia? The cyst is compressing your cervical spinal cord. That means your C5, C6 and C6, they are compressed. So, what did I tell you in the spinal cord lesions? At the site of lesion, you will have the lower motor neuron palsy. Right. So you will have LMN palsy at the site of lesion because of damage to your C5, C6. So that is the reason why, right? That is the reason why the individual is having loss of these particular biceps and as well as triceps jerk. Right? That is the reason why the individual is having loss of this biceps and as well as the triceps jerk. Okay, so in this clinical scenario, I have tried to explain you each and every single point of this particular clinical scenario. So it is a clinical scenario of Syringomyelia. Now the question is, how will you diagnose this Syringomyelia? The diagnosis of the Syringomyelia is by MRI of the spine. Right, the diagnosis of this Syringomyelia is by MRI of the spine. Right, now how will you treat Syringomyelia? Right, the treatment of Syringomyelia is surgical decompression. Right, the treatment of Syringomyelia is surgical decompression. That is the treatment of your Syringomyelia. Right, right. So if you have any doubts in this question, please let me know, I will answer. Did you understand Syringomyelia in a very conceptual manner? Yes or no? Recently, I have come across a video in the YouTube or some Facebook, right? A person in Mumbai was, right? A person in Mumbai was cooking in the boiling oil. From the boiling oil, he was taking all the substances with the bare hands. Right? With the bare hands, he was removing all the substances, whichever was there in that boiling oil. And later, he was examined and was found to have syringomyelia, right? So syringomyelia, you will have that painless burn. Yes, Ram, what is your word? No, you did not understand, or you don't have any questions? What do you mean by your reply? No, you did not understand syringomyelia? Yes, Asadullah Khan. Right. So Asadullah Khan is my close friend from Pakistan. Right. And he says that he has also seen a case in Pakistan also. Very good, Asadullah Khan. Right. Now, the most common site is in the cervical area. The second most common site, yes, Sandeep Chandra, the second most common site, it can be in the thoracolumbar area. Right. It can be thoracolumbar area. Right. So now let me just summarize all the clinical scenarios what we have discussed today. Let me summarize all the clinical scenarios what we have discussed today. Okay. So the first question what we have discussed, right? The first question what we have discussed is about the Parkinsonism. And in Parkinsonism, what is the first choice therapy? Levodopa, carbidopa. Right. And apart from that, what is the next first choice therapy which have been recently started giving? Dopamine agonist, that is rotigotin. Rotigotin can also be given, right? Next, rotigotin, rasagiline. So these are also the first line therapy for the Parkinsonism, right? Rotigotin, ropinirole, and as well as the pramipexole, right? Next, the second question was on Parkinsonism. The risk of Parkinsonism will reduce with cigarette smoking, right? Yes, yes, Asadullah Khan. Definitely they will have the other complications like secondary infections, because in the burnt area, if the individual is unable to recognize that burnt area, right, there will be secondary infections on the burnt area where the individual may land up in sepsis, right? Next. Now the third question was on the deep brain stimulation. The third question was on deep brain stimulation. So deep brain stimulation, the indication of deep brain stimulation is the presence of severe tremors and levodopa induced motor complications. We give deep brain stimulation. Okay. And where do we keep the electrodes? We keep the electrodes of the deep brain stimulation in subthalamic nucleus or globus pallidus interna. Next, the third question was on motor neuron disease. Which motor neuron disease I have described here? That is amyotrophic lateral sclerosis, right? In amyotrophic lateral sclerosis, they'll have both upper motor neuron involvement and as well as the lower motor neuron involvement. Okay. Next, the next question what we have discussed was about the trigeminal neuralgia. For trigeminal neuralgia, the drug of choice is carbamazepine, and the character of the pain of the trigeminal neuralgia will be a sharp shooting pain, and it is most commonly distributed in the ophthalmic division, right? It is most commonly distributed in the ophthalmic division. Next, the next question like what we have discussed was on syringomyelia. The next question what we have discussed was on syringomyelia, right? So in syringomyelia, remember, right? Please remember that they will have a fluid filled cyst. And how will you diagnose? They will have dissociative anesthesia. So these are the clinical based questions on neurology, right? So again, I will be live in front of you tomorrow to discuss some more clinical based questions on neurology. Right. So please watch the previous sessions also on Arise Medical Academy YouTube channel and utilize those sessions for your upcoming FMGE exams. Thank you very much and see you tomorrow again.